This is Dr. Wendy, and today I will be doing my presentation on common canine diseases, cardiac diseases, and kennel cough. So I am going to share my screen so that all our students are able to see the presentation. So just give me a second here. So we are, as I said, joining, for all the students joining me just right now, we are doing a presentation on cardiac diseases and kennel cough for under the topic of common canine diseases. So, what are cardiac diseases and kennel cough? Well, you may see a case presentation that with the symptom of coughing, which is very nonspecific and very general. And then we want to ask some important questions like, is this acute or chronic? And segment-wise, we want to ask whether this is a young dog or older patient and whether this animal is more active or mostly indoors and sedentary, because that is going to really help us determine what's going on in terms of our diagnosis, a specific diagnosis. And we will start with canine cardiac diseases. The most common canine cardiac disease will result in congestive heart failure. And there are three mechanisms of which this can happen. Number one, there's volume overload, and that will often occur from valvular diseases, mainly from mitral valve, which we will cover very shortly. There's systolic dysfunction, and that will often come from myocardial diseases, most commonly dilated cardiomyopathy, more commonly known as DCM. And then there is very rarely diastolic dysfunction, which is less common in dogs and more common in cats, and that is a condition called hypertrophic cardiomyopathy, otherwise known as HCM. I'm hoping everyone can hear me right now because I realized that when I am sharing my screen, it's really hard to see the chat to see what's going on. So I just want to make sure that everyone can hear me. And if anybody is having trouble understanding, I'm going too fast, going too slow, or if there's trouble seeing the screen, please just send me a message via chat. Excuse me. Wow, it's quite cold here. Sorry. All right. So, um, next, I just want to show a diagram of what I was just talking about. So, as I said, when there's normally there's the diastole, which is the filling phase, and then the systole, which is the pumping phase of the heart. So that's how you hear the lub dub sound, and then that's how you count one heartbeat. And when there's systolic dysfunction resulting from valvular disease issues, then the diastolic portion, which is the filling part, is um, having a malfunction. And then when the blood fills in, the blood won't completely fill in and will not be able to pump out properly because there's a dysfunction in the valve, so it's not closing properly. So the systolic dysfunction mostly referred to the mitral valve disease. And then the diastolic dysfunction, which is an issue with the filling part because as you can see, there is thickened ventricular muscles here that often comes from HCM or DCM, meaning that when the heart is starting to fill in the diastole phase of the heart pumping, the heartbeat, it's unable to do so properly because the ventricular chambers are too small. So that happens also in also results in congestive heart failure. All right, so let's talk about mitral valve disease. This is very important because it constitutes 70 to 80% of all canine congestive heart failure. And what happens is, I'm just going to briefly go over the pathogenesis. There is the myxomatous degeneration of the valves, and then the valve will thicken. There's regurgitation during systolic the systolic portion, as you remember here, the systolic pumping phase of the heartbeat, and then there is left atrial dilation. And then when there's left atrial dilation, as you can see here, the atrium are very big here. That means the heart isn't being efficient, not all the blood is going out, and then eventually congestive heart failure will happen. And the predisposed breeds are small breeds, such as Chihuahuas, King Charles Cavalier, and also the poodles, like the mini toy poodles, and it's worse when they have periodontal disease. So when you think periodontal disease, you're also thinking like your tiny breeds such as like Yorkies, such as Pomeranians, such as tiny Maltese. So those are all breeds that will be more predisposed. And there's a strong genetic predisposition as well. But it's very important to note that how loud the murmur is. So if you remember, there's 6 grades to murmurs. The murmur intensity does not equal to the severity early on in the disease. Um, And then, so just to reiterate, which breeds are predisposed? The mini poodles, the Shih Tzus, the Maltese, the Doxies, Chihuahuas, Pomeranians, so the small, tiny dogs, and then also the King Charles Cavaliers as well as Whippets. So those breeds are the ones that you commonly see for mitral valve disease. So we want to talk a little bit about like pathophysiology, but I'm not going to get into too many details regarding pathophysiology. But just to give everybody some gentle reminder that this is still very important to know how things occur. Not only will this appear often on the NAVLE or BCSE exam, but also owners may ask you regarding why this is happening to my dog. So it's the degenerative and thickening of the mitral valve leaflet and the chordae tendineae, which will lead to valvular incompetence and regurgitation from the left ventricle, and then that will then enlarge the left ventricle. So the blood will come in like this, and then the valve will be incompletely closed, and then it'll go down to the left ventricle and then enlarge the left atrium. And then this chronic regurgitation will then result in hypertrophy and then pulmonary venous congestion and then pulmonary edema. So that will be one of the reasons that the coughing will occur, as well as the left atrium enlarging. As you can see here, that is going to press on the bronchioles, the bronchi, the bronchial branch, and then irritate the trachea and the bronchial branch there, and then cause coughing. And then long-term wise, because the compensatory mechanisms, the RAAS, will eventually cause long-term volume overload and worsen the disease. So that will be end-stage cardiac disease and end-stage congestive heart failure. Okay, so stages of heart failure, just really quickly. Stage A is when there's no disease present whatsoever, so the animal is very healthy otherwise. Stage B2 is when we hear a murmur, often during the annual exams, we'll hear a little bit of grade 1, grade 2 murmur is detected. So then we ask our patients to get a radiograph and or echocardiogram done, and then there is no cardiac remodeling at this point, and there's no clinical signs of heart failure. So that's stage B1. And then stage B2, murmur is detected already, and there's like radiographic and echo changes and left heart enlargement, but there is no clinical signs of heart failure yet, okay? And then stage C is when we do have, when we do have some clinical signs of heart failure, such as like exercise intolerance, such as coughing, and such as, okay, sorry, there's some technical difficulties happening. All right. So, stage C is when there are clinical signs of heart failure, such as coughing or exercise intolerance, or sometimes there is purpling of the tongue. And then stage D, unfortunately, is the end stage heart disease that is not responding to any of the standard treatments. And then obviously, there's more severe signs of heart failure. So we want to remember when I talk about treatments that the pymodendin, we will want to start at stage B2. Okay, clinical signs. So in the stages B1 and 2, there's some incidental heart murmur that's often going to be systolic. And then in the later stages, C and D, there's going to be cough, tachypnea, exercise intolerance, and dyspnea. So as I said, those are when we see like the older little dogs with really poor dental health, and then their owners are gonna say, oh, like Fluffy's been coughing a lot lately, or he's not as active as before. After he is active, like his tongue turns kind of purple and he's panting a lot. And when he's sleeping, his like resting breathing rate is over 40 times per minute. So those are the times when you're like, uh-oh, this is definitely a time for us to do radiographs and echocardiogram and start heart treatment medications. And then when you are listening to our pets, they're also going to have pulmonary crackles and or systolic murmurs. And the pulmonary crackles will often come from the pulmonary edema, as I previously said, when there is volume overload. And then in advanced cases, the heart itself is going to enlarge. So cardiomegaly, there's going to be pulmonary edema, weight loss, and syncope, where they're just very excited, and then suddenly they kind of just faint. Just the owner will tell you that, oh, they never done this before, but they like was really excited to see me come home, or get some favorite treats, and then suddenly just like fall sideways onto the ground for like a minute or two, and then after a little bit they're able to get up again. So that's when they pretty much have what we see in a human world like as a heart attack, and then they faint. So how are we going to diagnose the mitral valve disease? So thoracic radiograph, we're gonna see left atrial and ventricular enlargement, and there might be some pulmonary congestion and alveolar edema, but these will often only be seen in stage C or D. So it's really hard to see to catch them early at stage B1, B2. And echocardiogram is actually the best way to detect our mitral valve disease patients quite early. So as you can see here, the left atrium and the left ventricle are very enlarged, and you can see the prolapsed mitral valve leaflets right here, and there's regurgitation on the Doppler. So this is definitely the gold standard of diagnostics. And we can also use blood work, including a proBNP or troponin 1, to look at the cardiac stretch and injury as their biomarker. So this can be done as a blood work. An ECG may also show a little bit of arrhythmia, but that's not going to be as specific and as accurate as echo. So as I was talking about, this is the X-ray, thoracic X-ray, in often a stage C or D canine patient with mitral valve disease. As you can see, the heart is very enlarged, is more than 3.5 VHS here. The left atrium is markedly enlarged and is pressing on the trachea and the bronchial tree here. That's what's narrowing the trachea and causing the cough often. And then also, as you can see here, the dorsal lung lobe here is quite patchy, and we're seeing the alveolar patterns here, and that is often a strong indication of pulmonary edema already occurring. So this pet definitely needs to have a echocardiogram to see how bad it is, and definitely need to start cardiac therapy at this moment. Okay, so just to see if everyone is really listening and keep everybody engaged, let's go through a sample question. So, what diagnostic finding is best to confirm a clinically significant regurgitation due to mitral valve ventricular disease? Is it gonna be A, systolic murmur, B, VHS, so vertebral heart score of 10.5, or echocardio evidence of regurgitation, elevated proBNP concentration, or pulmonary congestion on thoracic radiograph? So what do you guys think? I'm gonna go back to this really quickly. Oops. All right, go back to this really quickly. So that's the echocardiogram. And then this is the diagnostic approach, as I was just mentioning. Sorry, I was not very clear with the thoracic radiograph. You want a VHS score of 10.5 or more, meaning that if you go back to your notes, do you want to count between here to here and then here to here, and then you want to count on the fourth vertebra to see if it's 10.5 or more in terms of the length of this ratio to the vertebral column. But I think that's something that will make more sense to go back to your notes and then to make sure that you understand what the VHS is. However, thankfully, that digitally, if you have a digital radiograph and there often be tools to help you measure. Otherwise, if you were to measure manually, it's often very inaccurate in terms of positioning. So let's go back to this question. What do you guys think? What will be the best gold standard of diagnostic finding if you suspect that this patient have mitral valve disease in terms of cardiac disease? Okay, I will let everybody know that the answer is C, which is the echocardiography. As I was mentioning, it provides a definitive confirmation because it can actually measure and see the mitral valve degeneration. It can see the thickness and the dilation of both left ventricle and left atrium, as well as we can use the Doppler to actually visualize the regurgitation. So it's very important if you hear a murmur on a patient to strongly recommend that they book for echocardiograph to better understand what's going on and to catch the cardiac disease early. Okay, another sample question. So there's a 10-year-old King Charles Cavalier that presents for a grade 5 out of 6 left systolic murmur. And he has a mild cough and occasional exercise intolerance. And a thoracic radiograph the owner has already consented to do. And then it shows mild left atrial enlargement. So I want to know which of the following will best describe the underlying pathophysiology of the condition. Is it going to be A, congenital malformation of the mitral valve, B, degeneration and thickening of the prolapse of mitral valve leaflets leading to regurgitation, C, immune-mediated destruction of the endocardium, D, infection of mitral valve leaflets by bacterial organisms, or E, fibrotic narrowing of mitral valve annulus. So remember what the physiopathology of this, it definitely has to do with the mitral valve, but is it a congenital malformation? Well, this patient is already 10 years old, so if we're congenital, usually we'll see the clinical presentation a little bit early. Immune mediated, that was not talked about at all within this lecture, as well as again, our patient is already 10 years old. So if we're immune mediated, we assume that we'll see clinical signs way earlier than that. Infection of the mitral valve disease, yes, sometimes there is valvitis, so endocarditis of the heart, but again, it's very rare, and there was no mentioning of like poor periodontal health, and there's no mentioning of other systemic diseases, so it's very unlikely. And then the fibrotic narrowing, again, that is very rare, and from what we're seeing in terms of breed and the clinical signs as well as diagnostics run, it's very unlikely that this is the fibrotic narrowing. If it were narrowing, there would not be regurgitation much because usually it's the degeneration that's going to cause a malfunction in the systolic phase of the heart. So after the process of elimination, you can see that the answer is B, and it's because of the myxomatous degeneration that leads to thickened valve leaflets that fails to coapt properly during the systole, so that results in regurgitation and therefore the left atrial volume overload, causing the cough and causing the causing the mild exercise tolerance. So I want everybody to remember this is our poster child of mitral valve disease. And then just to remember that this is the degenerating mitral valve. That's a pathophysiology of what's going on there. And this is our VHS, as I was talking about, to measure the length of the heart compared to the vertebrae. And then if it's bigger than 10.5, that's strong indication that the heart is enlarged, but not a very specific diagnostic tool to see that we have mitral valve disease. And then, of course, this is a regurgitation from the Doppler to see that the blood is back flowing back from the left atrium back to the left ventricle. And this is the enlargement of the left atrium and the left ventricle. All right, so how do we treat this then? If they're only in the earlier stages of B1, where there's no remodeling, then we can still monitor and we don't have to treat yet. However, if there's already remodeling of the heart, as seen on an echo, then pymobendin is going to delay the onset of the congestive heart failure, and this is when this medication can be started. When our pets are already symptomatic in stages C and D, they're gonna need a lot more help. They're gonna need some furosemide to prevent pulmonary edema, and they're going to need pymobendin to help with the workload that the heart is taking on right now. So that's a positive inotrope and a vasodilator. They'll often also need ACE inhibitors to decrease their blood pressure. And then sometimes we will add in spironolactone and oxygen and dietary sodium restriction. Okay, one more question because again, this is very important. So we have a 12-year-old small breed dog with stage C mitral valve disease presented for coughing and mild dyspnea. Um, he has already done an echocardiograph and that confirms left atrial enlargement and pulmonary venous congestion. So what kind of medications, what combination should be most appropriate? Well, as I was saying, stage B1, don't need any medication. Stage B2, need to start on pymobendin. And then, and there's already pulmonary venous congestion too. So we do want to make sure that there's definitely some diuretics to get rid of the excess fluid in the lung. So what should we do here? We should definitely then start with some pymobendin, some furosemide, and some enalapril. And the enalapril is going to be because of the backup of the blood. So we're going to have to really regulate the blood pressure as well. So the correct answer, as I was talking about, is congestive heart failure requires diuretic to control the pulmonary edema, ACE inhibitor to reduce afterload, and to regulate blood pressure, as well as positive inotrope, which is the pymobendin, to enhance cardiac output. So here is just a picture of pymobendin. The trade name is Vetmedin, but I'm sure there are other brands that also make pet-specific pymobendin as well. So make sure we use the dosage accordingly. Prognosis. Unfortunately, the prognosis of cardiac disease is not great. It's a slow progressive disease. Median survival after congestive heart failure is usually 9 to 12 months. So we want to give our owners realistic expectations. And unfortunately, it's a progressive disease, meaning that it's irreversible and we can only try to delay the progression, but we can't go back to like stages B1 or stages A. And an earlier detection and pymobendin therapy will significantly improve the longevity. Okay, so moving on, we're going to talk about dilated cardiomyopathy. And this is a primary myocardiac disorder, so meaning it's often a genetic mutation. It can also be dye-related, related to taurine or carnitine deficiency, and very rarely can be also due to exposure to toxins. And is characterized by ventricular dilation and impaired systolic function. So and it leads to decreased cardiac input, neurohormonal activation, and eventually congestive heart failure. So, just to give everybody a uh, picture view of what's going on here, because I feel like often a picture is worth 1,000 words. So this is a normal heart, as you can see. And then this diagram shows a dilated cardiomyopathy. So as I was talking about that, there's gonna be ventricular dilation. So as you can see, the ventricular walls here are much thinner compared to the normal ventricular wall here, and then this causes a ventricular dilation here. And then when there's ventricular dilation, that means the systolic function, meaning that when the heart is trying to fill, is not filling as well because sorry, when it's trying to pump, it's not pumping as well because the ventricular muscles are quite weak, meaning that there's going to be reduced blood going out, and then that will eventually decrease the cardiac output and then congestive heart failure. And the right ventricle is often more affected than the left ventricle. And when the right ventricle is enlarged, unfortunately, this will cause backflow into the abdominal cavity, which then we'll see ascites. Okay, and this is the second most common cause of congestive heart failure in dogs. And the predisposed breeds are very different compared to mitral valve disease. We're looking at Doberman Pinschers, we're looking at Boxers, Great Danes, Irish Wolfhounds, and Newfoundlands. And often we are seeing more middle-aged to older males that are more predisposed. And Dobermans, unfortunately, have like a huge genetic predisposition. So we do want to pay more attention to our Dobermans when they come in showing clinical signs of any heart diseases. All right. So, what is dilated cardiomyopathy? As I quickly talked about in the first slide, what happens there's thinning and weakening of the heart muscles, like here, and then the um, right ventricle will really increase in size. And then the blood will pull in here and increase the pressure and stretching out the thin heart muscle, and it gives the heart a dilated appearance. Um, In the early stages, we usually just see some arrhythmia, often VPCs, and there's not a lot of structural changes. But in overt diseases, there's going to be, when they're in the stage of congestive heart failure, we're again going to see exercise intolerance, cough, dyspnea, syncope, abdominal distension from the ascites. So the first few clinical signs, exercise tolerance, cough, dyspnea, syncope, those are going to be very similar to mitral valve disease, but one more distinguishing feature is the abdominal distension, the ascites, because this is more affecting the right side of the heart instead of the left side of the heart. So the backflow of the blood will go into the abdominal cavity and resulting in fluids and resulting in ascites. And sudden death may occur due to ventricular arrhythmia. So, how do we diagnose what's going on here? Um, the thoracic radiograph, we can definitely see in later stages increased size of the heart, so cardiomegaly and pulmonary venous congestion often. And then we also often see VPCs, which are ventricular premature contractions that originates from the ventricle, and it should originate from the sinus node in the right atrium, but now it's originating from the ventricle. And then this beat will interrupt the normal sinus rhythm and result in an irregular sounding heart rate. I will show a picture of that in a bit so that you guys have a better idea of what VPCs will look like on a ECG. So that will help a lot more to remember what the distinguishing features of DCM is. And in echo, there will often be dilated left ventricle and left atrium, and also decreased fractional shortening. There's going to be thin ventricular walls and some regurgitation of the mitral valve or tricuspid valve, secondary to annular dilation. Holter monitoring sometimes could also work because of the arrhythmia that we can see in Dobermans and Boxer, and cardiac biomarkers such as proBNP and troponin 1. Those are also good indications of the cardiac muscles not functioning normally. And there's also genetic testing nowadays for breed-specific mutations for DCM. Okay, so on the radiographs, we'll often see this really weird enlarged reverse D. So if you take a look, it kind of looks like a D but on reverse. So it's a D on reverse on the um, radiograph, and you'll see a very enlarged heart that is also pressing on the trachea and the bronchial branch, which is often what's causing the coughing, but also the pulmonary edema. As you can see, the opacity here in the dorsal part of the lungs will also cause the coughing as well. So these are something that we'll commonly see in our radiographs. And then wanted to just quickly chat about the VPC again. This is a normal ECG, but if you see here, there seems to be this bizarre and wide QRS complex right here that's occurring earlier than the next beat. So right here, you see one, and then it's not associated with the preceding P wave. So the P wave, as you remember, P wave is this one. QRS complex is here. So as you can see, it's just occurring out of nowhere, and it's like a reversed QRS complex. So there's one here, and then as you can see, there's just lots here. Just there's a sorry, P VPC waves here and here and here. So if you see this on the ECG, that is not good. That means that there is urgent medications like lidocaine is often needed on an urgent basis here because this animal is having a very overt arrhythmia and his or her heart is not functioning properly and the beats are not providing the right amount of rhythm as well as not giving enough heart and workload, enough blood and workload for this animal to sustain in a healthy way. So, what should we do then? What are the treatments? How are the prognosis looking? So, when there's an acute congestive heart failure crisis, furosemide, oxygen therapy, pymobendin, ACE inhibitor, and stress reduction, you've got to throw everything that you really can for our pets here. And they often need to be hospitalized and stabilized to make sure that the pulmonary edema and or the ascites is gotten rid of. They're able to generate oxygen on their own, and this will often be a very, very emergency state. So that's quite important to note. But for chronic management after is, of course, pymobendin. Again, we want to improve survival. We want to increase the contractility. We want to help out I often tell owners that this positive inotrope is very important to really help out our pets and really gives a boost to increasing the workload and to help the heart function as properly as it can at this point. And then the ACE inhibitor and diuretics are very important to help with prevent volume overload as well as to decrease pulmonary edema and ascites, and then to control the arrhythmias. Sometimes we'll give like sotalol or mexilatine, but that is quite rare. Because often if we can maintain the workload and we can reduce the edema and ascites, we don't really need to use this long term. And of course, the nutritional supplementation, as I was saying, sometimes DCM is related to taurine and carnitine deficiency, so that should really be added. Make sure that your patient is on a nutritionally balanced diet, and then also to reduce exercise and reduce stress so their heart is not working overtime or beating too fast and they're too stressed out that their heart can't really deal with the arrhythmia. Prognosis of DCM is going to be more guarded compared to mitral valve disease. The median survival time after congestive heart failure is 3 to 12 months. And unfortunately for Dobermans, because they're so genetically predisposed and when we see them, often their disease is quite advanced. Unfortunately, the average survival will be 3 to 6 months post-diagnosis. Um, and just to go back again, the treatment for DCM will be diuretics, blood pressure medications such as the enalapril, and antiarrhythmic medicines, as well as the cardiac diet and the pimobendan. Okay, I am just very briefly gonna talk about hypertrophic cardiomyopathy because this is very rare in dogs, but way more common in cats. And what happens is there is left ventricular concentric hypertrophy, meaning that the left ventricle muscles become very abnormally and severely enlarged, meaning that there's not a lot of space for the blood coming in to be pumped out, and it's a diastolic dysfunction, meaning that it is a filling dysfunction, meaning that when the blood comes in, it just cannot, there's not a lot of capacity for the blood to be in here and to fill. So, and it can happen secondary to aortic stenosis or hypertension. And the signs that we see are often syncope and gallop rhythm. And a treatment is going to be beta blockers such as atenolol. There's clot prevention by clopidogrel and to avoid dehydration. So those things are so just a very, very brief overview. When I am going to be giving a lecture regarding cats, often we will discuss about their hypertrophic cardiomyopathy a little bit more. And again, the best way to diagnose this is still echocardiogram because we will be able to actually visualize the thickness of the left ventricle and we will be able to detect like the regurgitation of the heart a little bit better. Okay, quick summary of what we just chatted about. So mitral valve disease often happen to dogs, mainly because of mitral valve degeneration, and we're gonna often see this condition in smaller, older breeds. Key diagnostics is echo, and we'll see valve thickening and regurgitating jets. And the prognosis are pretty good to fair, and unfortunately it is progressive, but if we see them at like stages P1, P2, and have really vigilant monitoring and starting pimobendan at an earlier stage, they can live for quite some time and until they have like congestive heart failure, then their prognosis will be about 9 to 12 months at that point. Um, Dilated cardiomyopathy, we still see it mainly in dogs. It's because of systolic myocardial failure, and we see this mainly in large breeds. Always think Dobermans here. And the diagnostics best we'll see in echocardiograph, and we're gonna see dilated chambers and ventricular arrhythmia, such as the VPC. And the prognosis is more guarded because we usually see them a little bit later in the advancing stages. And then when they already have onset of congestive heart failure, the prognosis is not going to be as good. And then very rarely we will see HCM, hypertrophic cardiomyopathy in dogs because they're mainly a cat disease. And this is a diastolic dysfunction. And we're going to see concentric hypertrophy often in the ventricles. And especially purebred cats, such as exotic short hairs, such as British short hairs, Persians, they are more prone, oh, and ragdolls, they're more prone to HCM, and the echocardiogram will see a thickening left ventricular wall and left atrial dilation, and the prognosis, maybe variable. I have seen pets that go from from 6 months to 2 years, and they can be started on medications early, and as long as they don't have blood clots that cause thromboembolism or they're not too stressed to cause like a sudden syncope or sudden death, usually they can be okay for quite some time. All right. So just want to ask one more question before we finish up with cardiac diseases is when you see a 7-year-old Doberman that's presented with lethargy, coughing, and exercise intolerance, you note that there's weak femoral pulses, tachycardia with irregular rhythm, and a grade 3 out of 6 left systolic murmur. Then the owner agrees to thoracic radiographs, and then we see that there is generalized cardiomegaly and some pulmonary venous congestion, and the ECG also shows a VPC. Hmm, what are you thinking of at this point given this clinical presentation? Are you thinking of a concentric hypertrophy of the left ventricle? Are you thinking of thickened mitral valve? Are you thinking of a eccentric dilation of the ventricle with poor contractility? Are you thinking of a right ventricular outflow? Are you thinking of a hypertrophic cardiomyopathy? What are you thinking of that is causing this dilated cardiomyopathy of this patient? So remember, there's a Doberman, and you are seeing some ventricular premature complex, the VPCs, and you are hearing a irregular rhythm. What are you thinking of right now? Like, what is causing this cardiomyopathy at this moment? So, as we just chatted about, the correct answer will be C. You're thinking of the eccentric systolic dilation of the ventricles with poor contractility because, as we said, Dobermans, they're very, very prone to DCM, and then the DCM pathophysiology is because of the systolic myocardial failure that's characterized by a dilated thin wall ventricle. And the arrhythmia, I was chatting about, is very frequent, and we can often see a VPC on the ECG. So that will, I think, conclude our. Oh, no, I was wrong. There's another question coming up. However, this question will actually lead to our next topic of today. So, also about coughing, though. So, don't worry, this whole lecture will be about coughing, and it will be mainly about cardiac diseases as well as infectious tracheitis. Okay. All right. So we are also presented with another coughing dog, but different from the previous case. This is a 2-year-old unvaccinated mixed breed that has this harsh, dry, paroxysmal honking cough that ends with a retching sound. And then this dog just recently spent a week at a boarding facility. Fas- Uh, Physical exam is otherwise normal. There's no fevers, lungs are clear, no arrhythmia, and the dog appears to be pretty bright and active. Which of the following is the most likely diagnosis? Are we thinking of canine influenza virus? Are we thinking of canine infectious tracheobronchitis? Are we thinking about pneumonia? Are we thinking about collapsing trachea? Are we thinking about heartworm disease? Are we thinking about cardiac disease? Well, going into our next topic of the day, the correct answer here is kennel cough. And the differentials of which I threw up there as sample answers are going to be collapsing trachea, but these are mainly going to happen with smaller toy breeds, and that's chronic, and we'll often hear more of a goose honk that will occur, especially after excitement. And often this happens to older pets as well, because that's when their trachea starts to collapse and they so not signalment wise, it's less likely that a 2-year-old, otherwise young and healthy mixed breed is going to have a collapsing trachea issue. Pneumonia often will see systemic signs such as fever, lethargy, and we're going to hear some crackles and wheezes on upon auscultation of the chest cavity. And on the radiographs, we're often going to see alveolar patterns. Canine influenza, often there will be like will see a fever and more nasal discharge or more lethargy, but it seems like our previous patient there did not have any of those signs. And heartworm disease, we're often going to see in more endemic regions, and it's going to be more of a harsh cough, exercise intolerant, and abnormal lung sounds. All right, we're going to be talking about canine infectious respiratory disease complex, CRDC, often known as kennel cough, and this is a highly contagious multifactorial upper respiratory infection that's caused by a combination of viral and bacterial pathogen that will target the tracheal and the bronchial epithelium. And it typically will be a self-limiting cough, although some rare cases, especially for unvaccinated pets and or pets that are already having weakened immune system or really young or really old patients, they can progress to bronchopneumonia. And there is a high morbidity, but no low mortality, meaning that this is very highly infectious, but death rate, fortunately, is very low, and it can spread very quickly where there are high density of dogs. So often, kennels, shelters, daycare. That's why it got its common name as kennel cough. And the bacteria that often involve are Bordetella as well as Mycoplasma. And the viruses that are often involved are parainfluenza, adenovirus 2, and sometimes canine influenza, but rare, distemper and coronavirus. And co-infections is very common, and that will be because of the reduced mucociliary clearance. Pathogenesis, often by air and direct contact and formite, highly contagious. So after our patient does get kennel cough, is very important to separate them and prevent any contact of other pets for at least 2 weeks is often what I suggest. And the colonization of the bacteria and virus will be in the ciliated epithelium. It'll cause the cilia to stop moving, ciliostasis, and then increase susceptibility to secondary pathogens such as bacteria and other viruses. And the shedding, they can shed up to 3 months after post recovery. So it's very important after recovered to discuss with their common groomers and daycare facility that our pet just had Bordetella or just had CRDC, and it's quite important to separate him or her from other pets if possible. And seasonality can occur year-round, but more common in cooler months with indoor crowding. Clinical signs. When it's mild, sometimes just this dry, hacking, honking cough, a little bit of retching and gagging, but normal appetite and energy, and no fever. Moderately, can be more coughing, some discharge from the eyes and ears, and occasionally a lethargy and mild fever. And more severe cases, often to older puppies and immunocompromised pets, or unvaccinated pets, they can have some productive cough, of which they'll have phlegm, there'll be fever, dyspnea, anorexia, tachypnea, crackles or wheezes on the lung due to secondary pneumonia, and this may progress really rapidly to very rarely sepsis or death. Differentials, as I'd already discussed, tracheal collapse, laryngeal paralysis, the voice change, but this is very rare unless this dog also has hypothyroidism or is older and or foreign body. But foreign body, there also often be more distress or there's going to be more vomiting and more low energy. Lower airway wise can be chronic bronchitis to older dogs if the coughing persists more than 2 months, and a pneumonia if it's a productive cough, crackles, and fever, lethargy. Cardiac, again, can be common, but we'll often hear more murmur on our pets when there's a cardiac disease. And there can, another differential is systemic infections like distemper, influenza, but again, there'll be more systemic signs such as neurological signs, GI or ocular discharge. And parasites, yep, can happen when there's like heartworm diseases or irregular migrations of roundworms and or lungworms, but this will be a more chronic cough, and it'll also depend on the parasitic prevention of this pet as well as the regions of which your pet lives in. Diagnostics, thoracic radiograph, often can't see too much, especially for mild cases. And but if they progress to pneumonia, obviously we'll be able to see some bronchial or interstitial pattern. PCR panel sometimes we use nasal or oropharyngeal swab in them, and that can detect the Bordetella, Mycoplasma, canine influenza diseases, canine distemper viruses, etc. Tracheal wash, we can see some neutrophilic inflammation and some bacterial isolation, but usually I reserve the PCR panel and tracheal wash to our patients that are not responding to not responding to rest and not self-limiting, as well as if they're really unvaccinated and their clinical symptoms have worsened and not resolved in like 3 to 5 days. Chemistry, like blood work and CBC on usually we don't really see much. There may be a little bit of leukocytosis from systemic diseases, but often we don't see much in kennel cough. Treatment. So for more uncomplicated cases, usually resting in isolation will be great. So usually they should resolve in a week or two. If their coughing is really bad and really affecting their day-to-day activities, such as just coughing so hard they don't want to eat, or they're coughing through the night that it's really affecting their rest and or the owner's rest. Sometimes I'll go home with some hydrocodone, some butorphanol, and Lomotil as well, to really help them to feel a little bit better. And then humidification, nebulization, it can work. You don't really have to have a nebulizer at home. Often I ask owners to just bring their dogs into the shower, to the bathroom when they shower or have a hot bath, and a steam in there will often help moisten and help dilate their bronchioles and upper respiratory airways a little bit better and help soothe them a little bit better. So then usually we don't use antibiotics unless there's a really bad bacterial infection suspected, meaning that unless they're like having a fever, unless they are um, having productive cough or I suspect pneumonia, usually we don't really use antibiotics. However, with the complicated pneumonia cases, we want to target Bordetella and Mycoplasma, and doxycycline, usually for 10 to 14 days, will be our first line medication to choose from. I hardly use like azithromycin or amoxicillin for these cases because we know that doxycycline is going to penetrate a little bit better and has a anti-inflammatory component. So that's usually my first line of antibiotics. Again, the nebulization at this point the coupage and nebulization will help to kind of dissolve the phlegm and help them feel a little bit better to decrease the coughing, open up their airways. And oxygen therapy for really, really severe cases if they're hypoxemia, and IV fluids in supportive care, and bronchodilators in really, really rare cases of which breathing really becomes an issue. Prevention. Very important that to note and remember that vaccination will reduce severity and shedding, but not provide full prevention. The immunity is usually for 1 year, but it can be shorter in high exposed environment. So those pets that are often going to dog shows or really going to a lot of kennels that are very crowded, it's not wrong to recommend once every 6 months for the vaccination. And the vaccination type usually comes in an intranasal or oral type that will contain the Bordetella plus or minus parainfluenza, and that will help with rapid local immunity of the IgA. For the pets that really, really do not like nasal or oral route of administration, there is the injectable, but that's a slower onset because it's done by IgG. And sometimes for like some pets who are highly exposed, can also give them the canine influenza subcutaneous injectable vaccine, and that's optional and only in high risk populations. So just remember, there's the vaccine that's very common. So always try to recommend your owners to update the Bordetella vaccine to prevent this and to provide herd immunity so all canines are safe. Again, it does not prevent infection, but will reduce the severity and the duration of disease progress. Prognosis, really excellent for uncomplicated cases, can be guarded for severe pneumonia or distemper-associated cases. They may need a lot more supportive care and hospitalization. And chronic bronchitis can sometimes happen after repeated infections. Biosecurity and public health want to isolate the pets for about 2 weeks or a little bit more after clinical recovery. We do want to disinfect very well because Bordetella and viruses might be on formites and may be in aerosol for quite some time. Human risk, very, very rarely zoonotic, but for immunocompromised individuals, still isolate them from infected pets. Summary, the kennel cough is not one disease, it's a complex and a complex and a multimodal disease that are by multiple bacteria and viruses. Normal X-ray does not rule out kennel cough. PCR panels can be used for shelter outbreaks or for cases that are not self-limiting and or not responsive to first-line antibiotics. Distemper influenza should always be considered in coughing dogs that with systemic illness and or for unvaccinated dogs. And vaccination is preventative and epidemiologically critical for herd immunity to reduce outbreak magnitude. And coughing persisting for more than 3 weeks, we should always try to look at the other differentials such as tracheal collapse, bronchitis, or heart disease and or heartworm. All right, one last question for everyone. So we have a 5-year-old Dachshund that's returned from a grooming salon and developed this dry hacking cough for 3 days later. And we've already diagnosed as an infectious tracheal bronchitis and or kennel cough based on the history. But what are some following management plans that are most appropriate? Shall we start on antibiotics and corticosteroids? Should we begin furosemide and restrict exercise? Should we provide supportive care and cough suppressant if needed, and then vaccinate for Bordetella after recovery? Should we hospitalize for IV fluids and oxygen therapy? Should we perform a tracheal wash and culture in all cases? Well, as I just said, the correct answer here should be C, just provide some supportive care and cough suppressants if needed, and vaccinate for Bordetella after recovery. Because in this case, we still have a very young patient who's doing well otherwise, so it's going to be mild and self-limiting in 7 to 14 days. Supportive therapy can include humidification, can include rest, and a little bit of like antitussive, so cough suppressant if possible. Antibiotics are reserved for more complicated cases, and we don't want to throw antibiotics like candy out for everybody and then cause antibiotic resistance for everybody. And then vaccination, as I said, will prevent outbreaks, but we will do this after our pet has recovered. All right. If there's any questions or concerns, I am at the end of my lecture, so please leave me any questions in the chat, or if you think of something else after this lecture, can always redirect to WISE IAS, and then I'm sure our administrators can relay those questions to me, and I will help answer them. And hopefully everybody enjoyed that lecture and that this was helpful for everybody in terms of preparation for the BCSE and NAVLE examination. And I really hope to see everybody again for upcoming lectures to learn more about canine and feline diseases. Thank you very much for joining our class today, and I will see everybody again very soon. Thank you so much.